Pneumocystitis pneumonia treatment. The antimicrobial treatment for pneumocystitis pneumonia. We should contact infectious disease or HIV specialist. High dose cotrimoxazole, trimethoprim, and sulfamethoxazole remain the drug of choice. Administer 120 mg per kg daily in 4 divided doses, PO or IV. Dilute 480 mg ampoules in at least 75 ml 5% glucose. Infuse over 60 minutes. Use IV route initially and then PO during clinical improvement. PO may be used initially in mild cases. Side effects such as rash, nausea, vomiting, blood disorders are common, particularly in HIV patients. Consider routine use of antiemetics. Second line of choice, if intolerant or unresponsive to cotrimoxazole, include IV pentamidine, clindamycin, and primaquine, dapsone, and trimethoprim, and atuvacone. Treatment should be for 21 days. If pneumocystis pneumonia is strongly suspected and the patient is unwell, treatment can be started immediately as the sensitivity of bronchoalveolar lavage pneumocystitis stains only decreases at around 2 weeks. Empirical treatment is also required in the occasional situation where the diagnosis is suspected but bronchoscopy is non-diagnostic or not tolerated. In cases of HIV presenting with PCB, early introduction of highly active antiretroviral therapy HAART has been contentious with theoretical risks of drug interactions, increasing toxicities, and the potential for immune reconstitution inflammatory syndrome IRIS. However, a randomized trial and a retrospective analysis both demonstrated a 50% reduction in mortality when HAART was started within 2 weeks of PCB treatment. Suspected IRIS should be treated with corticosteroids plus or minus reintroduction of PCB therapy. Steroids. High dose steroids, prednisolone 40 mg, BDPO, or IV hydrocortisone are recommended for all patients in respiratory failure. Treat at high dose for 5 days, taper dose over 1-3 weeks, e.g., prednisolone 40 mg daily for days 6 to 12, then 20 mg daily for days 12 to 21. Supportive therapy. Hypoxia is common, so supplementary high flow oxygen is required, and we should consider use of continuous positive airway pressure CPAP or high flow nasal oxygen. Mechanical ventilation, if considered appropriate, may be required. Make this decision prior to initiating CPAP or high flow nasal oxygen. The outcome of the disease, mortality is 10 to 20% in the setting of AIDS, but 35 to 50% in patients with other forms of immunocompromise, probably reflecting the adverse consequences of the greater pulmonary inflammatory response to pneumocystitis, which is observed in non HIV immunocompromised patients. Mortality from PSP requiring mechanical ventilation in HIV infected patients is about 60%, although may be significantly higher in patients with low CD4 counts. Relapse rate in HIV is high, about 60% in 1 year, so secondary prophylaxis with cotrimoxazole is recommended, and primary prophylaxis is offered to HIV positive patients with CD4 count below 200 million per liter. The indications for prophylaxis in non HIV patients are less well defined. Consider prophylaxis for patients who are likely to receiving high doses of prednisolone for prolonged periods.